from RAC members and also non-RAC members. So we'll give an opportunity for RAC members to provide, oh yes, and the recording has started. Thank you, Karen. We will give an opportunity for RAC members to provide kind of an overview or summary or additional comments to what they've submitted. And I will start with Dan from MODA.
Good morning. Thank you. So I had 2 comments to make, one of which was recommending that the rules not require plans to submit medical necessity criteria for pre-approval, and I don't see that in the draft rules. So unless that looks like it's changing, we'll move on beyond that. The second comment really is reiterating the concern I brought up just as a comment in the last meeting. Worried that if we don't really plan for the implementation of the locus and CalLocus CASI, that it's going to be a train wreck for providers and for payers and for people seeking care. And so I'm making a recommendation that DFR establish a work group that brings in those stakeholders to figure out how we can implement this in a way that's going to work for everybody.
Great, thank you. And I don't see Melissa in the meeting, but perhaps she's on the phone. Melissa, are you here? All right. And we did, like I said, we did receive a comment from a non-RAC member, and we will provide time at the end of the meeting for public comment for anyone who is not on the RAC and wants to provide some comments there. All right, so moving on, yeah, Rachel.
Sorry, I just wanted to provide an answer to a question that Gary brought up last week. I had full intention of putting it in writing and then didn't, but wanted to make sure to acknowledge it during this conversation. It was around the 5E, if no in-network providers are available, essentially a one-time contract, a single case contract could be done with a provider for in-network rates, and the question was whether or not balance billing was allowed outside of that. The answer is yes. Our intention really was to create an opportunity for providers to work with a carrier to create a single case agreement, but not a requirement that one be used. So if no agreement is put in place, that there's nothing in there, that there was no intention to prevent carriers from doing balance billing in that case. So thanks.
All right, and that gave us enough time for Melissa to join. Melissa, we're going through the kind of summary of comments that we sort of start our meetings with. So want to provide you the opportunity to provide kind of a summary of your comments that were submitted.
Sure, my apologies for running late. I actually was on the wrong link and couldn't figure out what was going on. So yeah, just to sum it up, we just really wanted to express our concern. OIMHP wanted to express our concern with some of the practices happening around the state right now, and actually really around the country, by some third-party companies that contract with health insurers. And we really want to figure out with DCBS how to be proactive in making sure that questionable practices don't get released and put into practice, and then we have to react to them. Because as we wanted to illustrate, just having these sorts of policies in place and applying them, it has an effect of manipulating how providers provide care. And once that manipulation has started, it affects the way that we practice on a systemic level. And at this point, DCBS is primarily charged with protecting consumers, and so there really isn't a pipeline for providers to sort of sound the alarm about these sorts of things. but the systemic implications are that they end up affecting the type of care that consumers get. They could affect access to care if providers choose to leave panels. And so, we really want to advocate for some sort of pre-approval process being part of the reporting that insurers are required to do if they are going to use third-party criteria, as we've been discussing that the law does allow.
Great, thank you, Melissa. And thank you to everyone who provided comments. Like I said, we'll have a public comment period at the end for those who are not on the RAC and want to provide some public comment as well. At this time, we'll transition to our agenda item on network adequacy, and I will pass it over to Lisa to lead this portion.
Hi, everyone. Good morning. Thanks for being here. So as far as network adequacy goes related to House Bill 3046, we don't have any draft rules to present today, but I do want to follow up on our earlier discussion that network adequacy is going to be looked at on a broader level by the division, as far as it relates to mental health or behavioral health and medical and surgical. But at the same time, while we're in the midst of this rulemaking for House Bill 3046, it'd be remiss if we don't really take a close look and find out from all of you on the RAC, as well as interested parties, if there's anything that we should address more immediately related to network adequacy. So on April 6th, I sent out an email to RAC members with some materials to try to help you do some analysis and try to help you be able to provide feedback related to network adequacy for behavioral health. And so I'll show my screen, but basically what I put together was a crosswalk of the current of the references to network adequacy in the bill, as well as the related statutes, Oregon statutes for network adequacy, and in addition, our current network adequacy rules. Just so you're not, you wouldn't be having to dive into a ton of material on all different documents and screens. And it's helpful to me for my analysis of network adequacy as well. So that being said, really today, again, because that was provided in advance to give you an opportunity to review the material, but really it's kind of some just general questions as to whether, that I would like to give an opportunity today for feedback, and certainly we can get follow-up comments on this, but what network adequacy law or language in the bill do you recommend needs clarification in our current network adequacy rules? And also, what recommendations can you provide to help define what timely delivery of medically necessary behavioral treatment to an insured in a geographic area would be? Currently, our network adequacy rules have a national standard, which is related to the Medicare Advantage network adequacy standards. And those, I also provided the CFR, the Federal Register for those rules. And they quantitatively define time and distance standards by specialty provider and facility type, by county designation type, and also they provide minimum ratios for specialty providers and facility types per 1,000 Medicare beneficiaries. So I'll take a moment, show you this my screen, get to that document. Can you see my screen?
Yes.
Okay, thank you. So yeah, it's hard to see your reactions because I'm looking at the document as well. So I don't know if this document was helpful to the group, but and we do have draft rules. We need to have an adequate amount of time to go through today, but I'm just looking for some reactions to those just overarching questions. based on the material that I provided to the RAC. Gary.
Yeah, Lisa, when I circulated this question internally, when we do the Medicare Advantage, what we notice is there's quite a bit of a gap or lack of categories for behavioral health. What we saw was basically right now they do psychiatry and inpatient psychiatric hospitals, and that's about it. So I think we would have to create more categories, either develop them, or if somebody knows that CMS may be, or Medicare's, developing those, then we have to do that. Otherwise, I think it's going to be real limited and probably not getting to the categories or the level of detail you guys might want. So that was the first reaction I got is there's not a whole lot of categories for behavioral health right now with the Medicare Advantage standards.
Thank you. I noticed that too. Do I have an echo? Sorry about that. The better. Okay. Rachel?
Yeah, I had a question about the timely access, and apologies if it's just like right in front of me and I'm not understanding it. For the time and distance standards in Medicare, I really struggled to understand like what that worked out to in terms of like days, in including the language around timely as defined in rule. At least my folks didn't necessarily think that we were the experts and should be the ones to put that language into law, and wanted to have a conversation at the rulemaking level. But it really was around like literally like duration of time for folks to get access to care. So I'm really hopeful, they're really hopeful that we can have a conversation around like literal days. And then I think in the time since the bill passed, and I pointed this out in some written comments, California passed the timeliness standards. And I think that their behavioral health is 10 business days, so roughly 2 weeks. I think that made a lot of sense to our folks. I think we're also happy to engage in a conversation around whether we need to differentiate between sort of initial access, so you don't have a provider and you need to get scheduled with someone, versus you have a provider and need to make sure that that provider has enough availability to see you on an ongoing basis based on their recommendation or standard of care or what have you. Happy to have that conversation, and also really want to acknowledge the fact that it's the bill is written to require carriers to have more providers on their panels, but we also recognize that there is some ownership on providers to make sure that they have availability to see patients if they are on those panels. So if we need to have additional conversations around tools to make sure that those timely standards can be met, I think we're happy to do that as well.
Thank you very much. I noticed that as well, that it's not clear. We don't have clarity, I don't think, on the time for the initial appointment and also follow-up appointments. Let's see, I see Bennett, your hand is up.
Yeah, thanks. Good morning. I was actually going to make the same point about the California law, but I'd like to say that over the course of my career, especially here in Oregon, what I've seen is frequently people can get in the first time and they can't get a follow-up for a month or more. So I think something like this makes a lot of sense to me. The other thing that I think I've asked before, but I don't know if other people have thought this through, is how does telepsychiatry relate to access in terms of if somebody from Burns can see somebody through telemedicine from Portland, is that as good as being able to see somebody in Kearney County? I think we need to sort through that question.
Yeah, that's a very good question, and one I've heard, that we've discussed internally. And I'm not to put Tasha Sizemore on the spot, but if at any time, Tasha, you want to jump in and offer any insights, please do. Because telemedicine, I don't think is to be a substitute for an adequate network. It's obviously really helpful and important, but I don't think that we're seeing it as a, any makeup points, for just having that ability to do telemedicine. So Jen Baker, I see your hands up. You're muted, Jen. Okay.
Camera on. Sorry, I just wanted to say I appreciate Rachel's comments. I don't know if I would agree on 10 business days for behavioral health providers, but I think we should have that conversation and also, you know, detail more or more conversation about separating, you know, access to a new provider versus access to an existing provider. But the one thing I kind of disagree. I think much of behavioral health in terms of counseling, which is the bulk of what we see, that come in claims under behavioral health, are telehealth now. And so we do have to consider telehealth as some sort of standard to meet the network adequacy requirements. And if we want to distinguish between counseling and then inpatient treatment, that's fine. But I mean, I think it is where we have gone as a society, and that's where many people are at with their own counseling needs, including myself. So I would say that it's something that we do need to have a conversation about and discuss and potentially make room for in these rules.
Thank you for that comment. Let's see, I should go to, I'm trying to remember, see whose hand was up first. I think it was Chris, and then we'll go to Rachel.
Yeah, I'll point out, Rick just commented on this in the comments in House Bill 2508, telehealth can't be used for the purposes of network adequacy. I believe that was the final language. So while it's nice to have a conversation about it, there is already statute addressing that, even though that is sort of a consumer choice. And just a couple other comments. One, two, I'd reiterate, Medicare should be no standard by which anything is measured in behavioral health for the purpose, for the sole reason Medicare is the worst payer, worst coverage that you can have if you have behavioral health needs. And so, Oregon needs to have another conversation. Other states have done that. Not only has California passed more recently legislation, but it's managed care regulators had set standards a long time ago. NAMI doesn't profess the technical expertise to say what that language ought to look like, but it's clear that there are certain markers that we need to look at, and the language needs to address that. One is the huge disparity in out-of-network access, which existed prior to the pandemic. So you can't blame the disparity just on the pandemic. The other, as you get to timeliness, whatever data is out there, the Institute of Medicine data and every other study out there, timeliness matters in terms of engagement and care. And if you go beyond approximately 7 to 14 days, your no-show rate is significantly higher. Now, telemedicine may have an impact on that, and we don't have good research on that yet because that's such a new phenomenon. Nevertheless, and then there's standards that are already in law that we need to take into account, which is on discharge from hospital inpatient psychiatric care, there is a requirement that you try to get an appointment within 7 days. And so there are other hydraulics in the system that I think we need to contemplate as we talk about timeliness standards. But I would echo what Rachel says. It would probably behoove us to have a conversation around what is a day, putting day targets in there with the understanding that it's also going to take some work on all of our part to really build out provider panels. It's not something that you can just regulate and on day one, we're going to solve the issue.
Thank you, Chris. And also thank you to Rick for the reminder about that law. And this is a really good conversation. We're kind of starting this conversation on this topic. And so we'll keep it going. Rachel?
I just wanted to very quickly encourage this group to sort of separate teletherapy and network adequacy from the discussion. I think that especially in teletherapy, it is a different relationship than a telehealth relationship that you have with a physical provider. And teletherapy looks different based on whether or not you've got an ongoing relationship with someone in private practice, or you're engaging in sort of the larger big box BetterHelps and the like. And I think it's a complicated conversation that I think it's really easy for all of us to I will get really spinned up on it. And so I would just really encourage us all to separate it from this specific bill, especially with the passage of 2508. Thanks.
Thank you. Anybody else have any comments or thoughts on this? I think this was a really good, conversation starter, and we'll definitely take this back and think about it, and certainly be prepared to talk more about it at the next RAC. How are we doing on time, Cassie? I'm not looking at the agenda.
I think we are right on track. I think I want to circle back to a question, Lisa, that you brought up of DFR is going to be engaging in kind of a bigger and broader kind of network adequacy work, not just for behavioral health, but for kind of all spheres that we kind of oversee in terms of network adequacy. But I think the most helpful thing for us in thinking about if there is anything for network adequacy for this rulemaking is what potentially needs to be in place more immediately rather than waiting for this kind of bigger work. We're hoping to kind of streamline some of that work because it all kind of flows together in terms of the reporting and what we think. But what if any do we need now for network adequacy? And it's okay if there's not responses now, but I think that feedback would be very, very helpful for us moving forward before the next RAC meeting. Gary.
Hey, just figuring out, Cassie, a little bit is, as I sit here and think about this, is, as we look at the network adequacy, what comes to mind is, do we have a sufficient number of mental health providers to meet the population in Oregon? Because all the health plans essentially kind of touch the same providers. Some may have more exclusive providers than other, but just from what I've learned over the past few years, the health plans are putting pressure on the providers because we have our requirements. And in a year or two or now, do we currently have that workforce? I don't know if NAMI or some of the other providers may have those ratios or gaps there, but I think that may help it before we go around and start putting requirements on the health plans, because we're just going to in turn put pressure on the providers when there's not a workforce to support it.
Thanks, Gary. I think it's Chris's hand is up.
Yeah, I just wanted to address that. I mean, there is some data to suggest that we do have pretty good provider kind of licensure and all that kind of thing compared to other states, but it's imperfect. This conversation came up during the crafting of 3046 as we worked with carriers, and there was recognition that part of it was a carrier issue because rates were so anemic. Providers were disincentivized to even participate on panels. And part of it is a workforce issue. And that's, again, to my comment that, some of this needs to be worked out collaboratively so that we can improve the pool of providers. But there was a huge disparity prior to the pandemic, and yet there was low-hanging fruit in terms of getting more providers on panels that we just weren't pursuing, either carriers or by regulation.
All right, thanks, Chris.
Thank you. Rachel?
I was just going to add, in terms of data, that may be a question for the licensing boards. I don't know sort of what level of information they can share, but I have to think that they have some knowledge of the number of licensees and their at least vague geographic location across the state.
Thank you. Agreed. Anybody else? Thoughts? Melissa?
I just want to echo what has already been said, just that OIMHP conducted a survey, I want to say it was in 2017, of providers around the state who either had left insurance panels or who were considering leaving insurance panels, and asked for their reasons for doing so. And their top two reasons were either low reimbursement or decreasing reimbursement. And then the second reason was aggressive utilization management. And so we feel like, you know, enforcing the other parts of HB 3046 that have to do with those things are only going to be helpful to network adequacy.
Thank you very much. Right. Yeah, as I said, this is kind of a conversation starter, and I'll go ahead and give the floor to Tasha to give some feedback.
Hi, everybody. Apologies. I had to go in for some unexpected computer work this morning. I do have a follow-up question, though, around the conversation about the adequacy of the number of providers that we have in our network. So this is something that we have discussed at the division on and off since prior to the pandemic. And one question that has come up a couple of times is there a centralized database where providers can go in and put their information, and insurers can go in and, you know, collect information about availability or who might be on sabbatical or kind of like a whole host of options. Previously, there was a project through OHA to set up kind of a standardized process, and I know that that has changed, and the legislature removed the work around, or I guess defunded the work around that standardized portal of all the providers. And as I'm hearing insurers and providers talk, that may be an area of continued contention. And so I was just wondering if anybody from the provider or insurer side has, I guess, experience with a portal that would serve as a way for all of the insurers to check what the actual provider availability looks like. And I don't know if that question makes sense. I can't think of the name of the portal right now. I'm trying to search through my emails for it, but hopefully I saw Dan from MODA nodding. So I'm hoping that others also remember this portal and can help me with the name.
Yeah, if anyone has any ideas, please chime in. Until then, I see Jen Baker's hand is up. Go ahead, Jen.
I don't have anything on the portal issue, but I did just want to circle back on the discussion of reimbursement rates. I think if the DFR, you know, looked at our NQTL submission on rates, they would see that, you know, we are paying using the reimbursement methodologies that we're required to under mental health parity. And if you look at the parity data first and, you know, admit that there's a shortage of providers by, you know, everyone across the industry, and we're seeing this at a national level, like, I think that's something that has to be considered. So that's just something I wanted to follow up on.
Thank you. Okay, well, okay, Bennett.
You know, the thought just occurred to me. I wonder, because I've certainly experienced people dropping out of networks or not joining networks because of low payment. So I wonder if one thing that you could consider looking at is the ratio of available licensees that are participating in networks that are mental health providers versus other kind of providers.
Thank you. Yeah, I definitely think there's some data sources out there that we can drill into a little bit for those details. Like Rachel mentioned about the licensing boards. I'm sure there's data out there, and we can take a closer look at that. Well, unless anyone has anything else they'd like to share, we'll probably continue on with the agenda and keep this conversation going, think things over, and we'll receive any, we'll have a comment period for written comments too related to this subject, and keep the discussion going and include it in the next RAC as well, next RAC meeting. Thank you.
Great. Thanks so much, Lisa. And thank you all for a good start to our network adequacy conversation. Definitely more to come on that one. Moving on into the agenda, we will start looking at our draft rules. And Karen, I don't know if you have those available and can pull those up just at your convenience. What I'm going to do is I'm going to quickly go over the first three rules to begin with. Most of what is changed in those first three are really technical in nature, and hopefully we'll be quick to discuss so that we can spend most of our time with 1405, which is where the bulk of some of our discussion, I think, is going to lie. So starting off with, and Jen, I'm going to address your concern with the first rule, which is around essential health benefits. There is a change that was made to 1B, and I will confess it was me and it was my error. I misunderstood kind of our essential health benefit process and also had a jet lagged brain on Friday and probably should have made those changes, kind of conferred with my team. We are going to be removing that language and not making that change. So hopefully that addresses your concern, Jen, but I'll let you speak up if that does not address it.
You're good. Thank you.
Okay. Apologies if I set off alarm bells with that one. I blame getting back from vacation and jumping into complicated rulemaking right after that. Moving on through the essential health benefits rules, we do have in the draft the current version of DSM in the rule. I know it's been brought up about making that more specific, and we'll likely be looking into making that change. Want to open it up to see if there's any conversation about that. Basically, we would just plug in the actual information about the most current version of the DSM, which I think is 5. I could be wrong on that one, but we'll make sure to put in that specificity.
Yeah, it's 5-TR that it just came out in March. Tasha had flagged that for us, so you know we can provide specificity on that.
Perfect. All right, and moving on, we to the next change. There are some changes around kind of updating some language to align with the updated telemedicine statute that passed in 2021. And that is all of the changes for the essential health benefits rule. Any other comments on that one? Gary?
Yeah, or Jesse, on this one, I see a change from being mental and nervous conditions to the behavioral health. Is that going to be common theme throughout the rules, or is there something else behind it, the change in terminology?
Yeah, that change in terminology is to align with House Bill 3046 and is changed throughout the document or throughout the rules that reference that statute. So changing the terminology to be in line with how the terminology changed in House Bill 3046.
Is that going to cause conflict with other statutes that use mental or nervous condition?
I don't believe so, but we'll take that back and we'll make sure to take a close look. I think when Lisa and Brooke were looking at these rules, they made sure to try to catch it everywhere so that it would be cohesive.
Okay, I want to make sure that if we change it here, that it's not going to cause problems with other statutes that we have out there.
Absolutely.
Mental
Lisa.
Yeah, I mean, and so we appreciate any of your feedback on that, because we had that same question, but we, because the language was changed in the bill, we needed to clean up the terminology and the rules definitely removing nervous condition, but we were wondering on the question of keeping behavioral health and mental, those two words in together, or are they one and the same? You know, or is mental is included in behavioral health. So we did find a rule that we needed to pull in. Actually, this essential health benefit rule to have the language match. So please, yeah, we would appreciate additional feedback on your thoughts on that.
Thank you.
All right, moving on to the Dan.
I was just going to say, it seems fine to me, particularly given that it's defined in 3046. Behavioral health benefits means insurance coverage for mental health treatment, services for substance use disorder. So my understanding is behavioral health includes mental health and SUD. And so it's a blanket term that encompasses it all and does it in a nice economical way.
Awesome. All right, we'll move on to the next rule, which is around some definitions for coordination of care and case management. Most of the updates in this rule are truly just around some statutory references and also that terminology changing. So as you can see with the first one, it's just taking the chapter law and putting in the actual statute that was changed by the law passed in 2017. Pretty straightforward changes for this one. So we can move on to the next rule, which are some more definitions around non-contracting providers and comorbidity disorders. And I will start off and preface this. There is a numbering issue with how kind of the list is here. We'll make sure that that's changed in a future draft, but for the purposes of this conversation, we'll keep it consistent with the document we have up. So for 1B, and I think Dan, you might have already answered this question, we included substance use disorder in the definition of behavioral health condition, and we just wanted to double check with the RAC if that worked, or does substance use disorder need its own definition for the purposes of these rules? Gary.
Well, I thought we had to keep it, wasn't this tied to ABA when all that was coming up? And that's why we had to specify the Diagnostic and Statistical Manual version. I thought that's when we touched these rules when ABA therapy back in 2014 or so. So I'm not sure if it's good that we start taking this stuff out. And others, I mean, the division put bulletins out on these things. Has the division taken a look at those old bulletins from 14 to see if by modifying this rule, does it impact other areas?
We will be taking a look at that and making sure that kind of if there are updates that need to be made to those bulletins and whatnot. And so I think just to reiterate your concern is if we change kind of the definitions that are used in this rule, what happens to the bulletins that might use terminology that we're changing?
Yeah, because like Dan said, you know, if behavioral health is going to capture mental or substance use disorder, that may be fine. But I think just going from past experience, I thought this was going to touch on the whole ABA therapy issue when that came up. And that's when we had to get to DSM 4s and 5s, and that's why we had to be so specific.
DSM, oh, sorry, was in the original Parity. So it's been referenced since the first rules in 2006.
Okay.
And DSM, I mean, it includes substance use and addictive disorders in the DSM. So unless there's a conflict with the way I think DSM defines that, then as long as you reference DSM and define behavioral health and include substance use disorders, I think you're in good shape. But again, I don't know whether or not that there is some application to the ABA stuff, but DSM has always been referenced.
Yeah, but I think, Chris, is when we did that in 14, there was a reason, and I can't remember why we called specifically the 4th edition and 5th edition.
Well, the DSM-5 came out, so there was a
Right.
transition between 4 and 5.
Right,
So
but I thought
some
it was
of that
something with the,
conversation was what if somebody still use, how do you can't, how fast can you adopt a whole new DSM?
yeah, okay. Like I said, I don't recall all of those, but I remember that was key in this rulemaking is we called out certain things. And that's why I want to make sure we don't impact some prior guidance that's out there by making these changes. Thanks.
No, I've made note of that, and I see Tasha's hand
Yeah.
raised. So Tasha, if you want to jump in.
I think I remember this part of rulemaking back in 2015, and there was some questions then about items that were contained, and I don't have my DSM in front of me, that are contained in the back portion of the DSM that are like the V codes and other things. So it is my understanding from the conversations that happened back in 2015 that some of those V codes in the back of the DSM, insurers were not wanting to recognize those as full-on conditions as they had moved from V codes or something that the American Psychological Association or whoever had been monitoring. And so there was an effort made to kind of walk the line. I think that now our understanding of mental health parity and our application of the law, really, if it's a diagnosis in the DSM, it should be covered, is my understanding. So I don't know how we would handle this in this particular situation, but that's some of the background to why we did something weird with the old DSM version.
Yeah, and I think, Tasha, what we also did is we got specific because if you say in the current version, I think some of the lawyers got in there, and current version means as of the day that the rule was adopted, or is it as of today of the diagnosis? I think that's when some of the lawyers got in there and were saying they need to clarify the specific edition, just to throw a little bit more behind that.
Yeah, and we're planning to update the definition to include a more specific. So anywhere where it says current version or is less specific, we're going to update that throughout the rule to be more specific for those reasons.
Right. Thanks, guys, for stirring up those old memories of 2014 and 15.
It was
way
good
back
time.
when. Dan.
Yeah, so, first thing is current version aligns with the language in 3046. And so if we get more specific in rule and say DSM-5 or 5TR, I'm a little concerned about whether that could set up a conflict with the statutory language. Thinking about the rulemaking, Gary is, I think, onto something that there was some reason that they kept 4, and I don't remember what it was either. The thing about V codes was V codes are not they're not mental disorders. There are other conditions that may be a focus of clinical contention, like an argument with your neighbor is a V code. And we want it to be clear that that is not included in the mandate. And so the language that prior language or in the current draft means any mental or substance abuse disorder covered by the diagnostic categories. That word disorder was key to making it clear that we're not mandated to cover the V codes, or now they're Z codes, I think. But that was very intentional language at that time. Last thing is the ASD, autism spectrum disorder thing. That might have been involved in the 4 versus 5 thing, but I don't remember. It's not clear to me how that could be, because autism spectrum disorder is well covered in DSM-5. So but yeah, if we could look back, if somebody could figure out why was it that 4 was kept in, it might be what, I don't know what it is.
Tim.
I don't know for sure. I have no idea what the reason was in 2014 in Oregon, but I do know that the autism thing that did come up in a bunch of states with concerns about 4 versus 5, DSM 4 versus 5, is that certain disorders like Rett syndrome and several other things that are now considered just autism spectrum disorder that were explicitly named as a condition in DSM 4. There was concern that if you go to DSM 5, those conditions wouldn't be swept in and covered, even though they are. It's just that there's the ambiguity in going to DSM from DSM 4 to DSM 5. People weren't sure about that, so they wanted to lock in for sure that coverage of certain children that had. I also think childhood disintegrative disorder was one of those conditions. So that was just my context from having studied this back then from a bunch of other states. I don't know that that's what happened here in Oregon, but I do know that that was one of the reasons why DSM-4 got held into state law and certain autism mandates and definitions. So it could be that, but I certainly don't know for sure. I'm just giving a little insight in what happens in other places.
Yeah, thank you, Tim. That's helpful. And I think I've written a note. We'll go back and check kind of our regulatory guidance, particularly the bulletins that we have around this, to make sure that kind of if we need to do some updates or if we need to keep some language, we'll bring that back to you all at our next meeting. So I'm going to move on for the sake of time, so we can get to some of the other rules. The other changes in this, we did remove the definition of chemical dependency. That's in line with the statute. And we will update that DSM reference, especially after we double check our bulletins and other regulatory guidance that we have to make sure kind of that they all work together, or we'll make changes that make sure that they all work together. We did include the statutory definitions for both generally accepted standards of care and valid evidence-based sources. These are not different from the statute, so they should look very familiar to everyone. Gary.
Hey, why were we adding those? Because I agree that it's the same thing that's in the law already. Why did we want to parrot those in rule?
I think it's just for use of kind of referring to it when you're in the rule and those phrases are used, that you know what the definition is. We've done this with other rules before, and I think even the reporting rules, we ported in the median maximum allowable reimbursement rate.
Right. I just want to express the concern I have is sometimes people in the future may think these can be adjusted and they're not, you know, if they're set in statute. So that was just my concerns when we parrot these in the rules. So just making that.
Thank you. All right, we'll move on to 1405, which is, I think, where we'll have lots of conversation. It's about the general requirements for coverage of behavioral health conditions. Starting with number 1, the changes made to this section were to update verbiage to include the language aligning with the federal mental health parity law around the predominant and substantially all tests which are required under federal law. Those are the changes for the first paragraph. Dan.
Thanks. I would recommend adding the word quantitative in front of the word limitations. The reason being that, so you've got your QTLs and your NQTLs. The predominant and substantially all tests only are relevant to the QTLs, and they are not applied towards NQTLs.
Great, thank you. Tim.
Yeah, I would second that. And I think that's important to put quantitative in there. Also, it's not a big deal, but you might want to change the statutory reference there from, that's the ERISA, 29 USC 1185A is the ERISA statute.
Oh, yeah.
Whereas, so you might want to go to the Public Health Service Act statute, which is what the state has the authority to implement.
Thank you for that clarification. Important for us to have that right in there. We'll make sure to make those changes moving forward. All right, moving on to the second paragraph. This integrates some statutory language around utilizing the same methodology for reimbursement rates and for these to be updated in an equivalent manner. And I think, Dan, you all had some comments on this, and others might have comments as well. So I'll open it up for conversation.
I'm not sure what my comments on this one were, unless you're referring back to a letter that I wrote like eons ago.
So these are some notes from Brooke, and I think it was about asking for kind of some flexibility if the provider and the plan both agree to, and maybe this is what Rachel was referring to, the single-use contract agreements around reimbursement, or no, this would be different. Entering into contracts with reimbursement methodologies that are different than a medical surgical provider. So
Brooke did her homework. Good for her. That was a letter that I wrote some time ago. So my ask here was there may be times when both the provider and the carrier view it as favorable to use a methodology that differs from the standard methodology that carriers use for their medical providers. And I want there to be flexibility that if both the provider and the carrier agree that kind of a deviation is mutually beneficial, that we ought to be able to do that. So an example of that is there are our standard methodology is either RVUs and conversion factors or percentage of Medicare. We're moving towards percentage of Medicare. Well, there are a lot of HCPCS codes that Medicaid providers use, community mental health programs, other COA organizations use these HCPCS codes on a very regular basis because they're reimbursable by Medicaid. But there's no RVU, there's no percentage of Medicare that you can use to price those codes. And so we want to be able to say, we want to have, a set fee schedule for these codes if it makes sense from both parties' perspective to do so.
Melissa.
Yeah, I just want to express a little bit of concern and say that I would want to tread lightly on making this provision more flexible, because we just got to a point now where we're going to be asking insurers who don't already do this to reimburse behavioral health providers in an equivalent manner to their medical providers. And, we're doing this because there is a history of rate suppression at the behavioral health level that wasn't happening at the medical level. So I want to just tread lightly and be cautious about making this more flexible. And just that if we were going to do something like that, we would have to be really careful, because the other thing that's really different about behavioral health providers versus medical providers is a lot of behavioral health providers are solo providers. They don't necessarily practice in large groups. They don't have bargaining power. And so I don't know if, an insurer and a solo provider are coming to the table, if they're really on equal ground, particularly if that insurer, for instance, I'm just thinking of an example here, would say something like, our panel is closed, other than to be a situation where you as a provider are going to agree to be reimbursed differently. Is that something you would agree to? And, I just want us to be cautious and thoughtful about that.
Thanks, Melissa. And we'll take the comments back and consider them. Jen?
Yeah, I kind of just want to respond to that. I understand that some providers are sole practitioners, but they have the ability to form provider groups that have more leveraging power, that, and I thought that was a large part of what we're trying to accomplish here, is to align the reimbursement methodologies with medical providers for our mental health providers. And so I think, they have that ability that would give them more resources and more leveraging power. So I think it is their choice to maintain solo practice, to maintain a solo practice, but it is not an absolute must. So.
Melissa?
Yeah, just as a solo practitioner myself, I just want to sort of speak to that. I think that that's something that a lot of behavioral health providers want to preserve, is our ability to be independent practitioners and to not go the way of medical practitioners who have been, sort of in a certain way, sort of forced because of the nature of the market to kind of group together and become part of these large conglomerates that are like conveyor belts, where they're run by business administrators rather than practitioners. And so, I would like to think that we don't have to do something like that in order to be treated equivalently to medical providers. And that's the reason why we're going to the law and going to these rules, to make sure that our providers have the freedom to practice independently and to still be treated equivalently to medical providers.
I do need to respond to that. I agree, but I mean, medical provider reimbursement methodologies were based on some of these equations, and including, having provider groups. And I understand you wanting to maintain a solo practice, but I mean, again, if you want to be treated like a medical doctor, you have to have all those considerations included. And frankly, solo practitioners also do things that we feel puts, is by not submitting claims directly, forcing clients and patients to submit claims directly to insurers, is really bringing, the member or the patient into the equation when it's, not necessary to do so. So I think, again, that's fine, but you can do that. And I understand you want to do this, your own way, but the medical provider reimbursement methodologies were created for these reasons.
Bennett?
Well, this becomes more of an issue for me when I hear about something like the HCPCS codes, because there you can't apply the usual methodology. But I wonder if there's a way to protect providers by, so one of my thoughts is the state has a rate structure for HCPCS codes, and it might be one way to look at it is what's the comparison of HCPCS codes versus regular CPT codes in the state fee schedule. And I just wonder if that's a way to keep this from being an unequal negotiation between an insurance carrier and somebody trying to deliver these other services that aren't usually reimbursed in the manners like that use CPT codes, which are easily translatable.
Thanks, Bennett. And I had a question around the HCPCS code kind of example that was provided, and similarly wonder kind of, are there references that we could put in, not necessarily providing like more flexibility, but saying something in instances where a HCPCS code is used, this is how you would do it. Or are there examples on the Med Surg side of how HCPCS codes are reimbursed that might be useful? I guess I'm just trying to kind of figure it out, so we're not necessarily, if there is this kind of gap with coding with HCPCS codes, how we address that. Bennett, I think you have your hand raised.
No, I forgot
Okay.
to unraise it, so I'm good for right this moment.
No worries. All right, Melissa?
Yeah, I just want to follow that up and just say it really actually, we kind of went off on a little bit of a tangent there, and it really is irrelevant what an individual provider is or is not choosing to do. I just advocate that we follow the law as it's written, and the way that number 2 is written is in line with the law, and I advocate that we stick to that.
Thank you. All right, seeing no more hands. If folks want to get back about the HCPCS code issue, sounds like it's in the minority of reimbursements, just kind of based on this conversation. But if we do need to add some language to kind of capture that, or to create a standard for how to do that methodology comparison, would love that information. Bennett.
I just want to ask a question from the insurance point of view. So if you talk about alternative payment mechanisms, such as case rates or what have you, how translatable is what's happening in the med surg side going to be to the behavioral health side? I'm just curious how you're going to make that translation.
I guess I can take a little bit of a stab at that. I don't 100% understand the question, but for alternative payment mechanisms, one thing that I have seen is on the med surg side, it seems like a code tends to be bundled as a one and done. So you're going to use a code for a hip surgery, and that's going to encompass the entire thing. Whereas in behavioral health, when we are trying to do case rates, it ends up being like a monthly rate, or for a period of time, because behavioral health treatment typically is not a one and done kind of deal. So that's one difference that I see. And then just sort of on a more abstract level, for value-based reimbursement, a lot of the value-based reimbursement schemas for medical tend to be related to HEDIS measures, which we have not found any useful way to incorporate that in behavioral health value-based reimbursement. Also, a thing that's made value-based reimbursement really challenging in behavioral health is the fragmentation of the system of care. So typically, you need a certain amount of volume of patients for a contracted entity in order to be able to apply a value-based payment meaningfully. And when you have a predominance of individual practitioners, you just can't get the volume in order to get the metrics to a place where they need to be in order to implement those kinds of things.
Yeah, I understand that, and I appreciate the difficulties, and I also understand that's where a lot of people want to move. And so my question is, for the purposes of this rule, is how do you, since it's supposed to be a same methodology, right, for behavioral health and medicine, if you're going to pay a monthly case rate for behavioral health, which, how do you make sure you're treating it in a similar way? I think that's what this rule needs to deal with, is because I think this is going to be there's going to be an increasing push to move towards this kind of reimbursement. I don't have the answer. I'd give you the answer if I had it. I'm just saying we need to anticipate this problem.
Yeah, the statute does carve out what I think of sort of as a safe harbor for value-based reimbursement from that requirement. So and it's really valuable, to reuse the word, that it does that, because that I'm hoping that preserves some of that flexibility.
All right, thank you all. We're gonna move on because we are quickly running out of time as we have these robust conversations. Moving on to paragraph 3, this integrates statutory language into the rule around reimbursement for out-of-network providers and making sure that they are reimbursed on the same terms and in parity with Med Surg, out-of-network Med Surg providers. Continuing to move on to paragraph 4, many of the changes in this paragraph and the subsections are really technical in nature and are just changing the terminology from mental or nervous to behavioral health condition, and also removing chemical dependency. In sub-paragraphs F and G, we do integrate some statutory language around kind of coverage may not be limited for a pervasive or chronic behavioral health treatment condition. And then also some language around what coverage must include for outpatient coverage that includes follow-up in-home services or other outpatient services that are necessary. Any questions, comments, concerns about 4? Melissa.
I definitely want a little bit more time to review this with my team of people, but something jumped out to me about G and just the way that, you know, the policy may limit coverage only if clinically indicated under any medical necessity, utilization, or other clinical review. I'm just wondering whether this allows for any loopholes. You know, when you take this and with other sections of the law, it seems like it doesn't, but, you know, or other clinical review, you know, what exactly does that mean? How do we make sure that that it's clinically indicated? You know, the phrase clinically indicated was used twice, and then, you know, we've kind of got medical necessity, we've got utilization, and we've got other clinical review. It's just something that jumped out at me, that it just seems like there might be some space for some cracks in there. And so it's just something that I am going to be thinking about with my group.
Sounds good. And like with all of the rules, we look forward to getting your feedback as we dive into it and have these discussions, but also as you take this back to your teams and dig into it a little bit further. Dan.
Thanks. Just one kind of general comment about this. Some of this language, it seems like, is copied and pasted from the statute. And I'm not really sure what the purpose of that is, but I don't have any objection to it. In other, the language appears to be sort of paraphrasing what's in the statute, trying to say the same thing, but in slightly different words. And that does raise a concern for me. Because they could be interpreted differently if the language is a little bit different. But if it's not clear that there's a specific purpose for the language to be different, it seems that that could cause ambiguity that could cause problems. So I would advocate for, if you're going to reiterate the language in the statute, do it exactly.
Thanks, Dan. All right, we'll continue to move on. 5, 6, and 7, mostly just update terminology. There aren't many other changes besides making those updates to the terminology changes. Okay, we'll move on to 8. And this is when we're sort of getting into the generally accepted standards of care and clinical review. So this outlines the requirements for behavioral health treatment diagnosis that are not related to level of care placement decisions. Any comments? What's missing? Gary?
Yeah, I was a little confused in reading this one. Cassie, maybe you can help me, because in 8, we say that currently generally accepted standards of care. Is it, so when we do our utilization review, is it just the generally accepted standards of care, or is it, and on top of that, you have to also follow the nonprofit professional association? Is that what we're trying to get at? So that in essence, you're forcing us to have to incorporate the nonprofit professional association guidelines. I'm trying to understand how you want us to read that.
Yeah. I'll make note of it so that we can talk about the and versus or, which is a perpetual debate in many of our policy conversations. I'll make note of it so we can take it back when Brooke gets back into the office and we can have a conversation about it.
Yeah, because that same thing holds for sub 9 and sub 10 also. It seems like the generally accepted standards of care is broad in its definition, but then in this rule, it pulls it down and ties it to the nonprofit guidelines. And I'm not sure if the bill allows that.
So if I could, I just want to chime in and agree with Gary on this, because I was confused by the way it was written. And I've kind of had to go over it a couple of times, because at first I'm like, well, maybe we don't include the word not, but no, that's not right. And so I think Dan is right when his comment that using the exact statutory language would probably be a better idea here. But it was our understanding that we could use other criteria other than a nonprofit association standard. But I could be wrong.
Great. I think, Chris, you have your hand up.
Yeah, so I think that this gets back to our original letter, and we'll dive more into this tomorrow. We haven't really looked at this, so we're doing that tomorrow, and we'll have more written comments and details. But I think this area gets into a concern we raised in previous submission, which is ensuring that what the legislation doesn't allow is using other criteria to undermine the level of placement determination, and also making sure that somehow a bad actor is not using other criteria to undermine the treatment that is available within particular level of placements. And so that I interpreted this language as getting partially at that concern that we raised. Again, we don't have comment yet on the specific language, and that we'll start developing that tomorrow.
And I agree, Chris. And Cassie, what I'm kind of looking at the other side is, are you making it so narrow that we can only use one particular way to do things, as opposed to having some flexibility? So that's the other side of the coin.
Dan?
I just want to remind people that, Representative Nose's letter to the RAC reiterates that he specifically wrote the language to allow carriers to use other criteria that are not the professional society standards. That was a deliberate decision that came out of the negotiations in the bill, and it's important that legislative intent be preserved.
I think it's also important to note he didn't intend that criteria to undermine level of placement decisions. That wasn't part of the negotiation. So just
agree completely.
Yeah.
I agree with you completely on that, Chris. That's
Melissa.
Well, and I just want to point out that the letter that we submitted here is really pertinent to this section, and just our concern that if other criteria are to be used, how do we make sure that other criteria, as everyone is saying, are not undermining treatment or access in some way or another, because what is other criteria based on? It could simply be numbers, and that's kind of what we're seeing out there is using numbers to determine rather than medical necessity, rather than generally accepted standards of care. And looking at the definition of generally accepted standard of care, some of the provisions under there is that they're generally recognized by healthcare providers, that they're not primarily for the economic benefit of an insurer or payer. And we just want to make sure that other criteria, if they're used, if they're internally developed, or if they're developed by a third-party company, that they are in compliance, and that they are in compliance with the generally accepted standards of care, and are not just based on statistics. Just because numbers are involved, it doesn't mean that it's based on generally accepted standards of care.
Hey, Cassie.
Yeah, Gary, sorry, I was looking for my unmute button and my computer was going slow.
No, just to respond to Melissa on that, they do have, providers and members do have a path, the appeals process, and if they don't like that, where it gets, the treatment plans do get reviewed, they can go to an IRO, and that's a completely neutral party that can review what we're doing. We submit all our information to them for review, so there is a path. If there is some questions about our utilization management.
Yeah, I appreciate that, Gary. I think that what we've really seen, though, is that this sort of reactive approach has not been useful, because consumers don't always know what that path is. And at this point, a lot of the pressure is being applied at the provider level, not to the consumer. And the providers don't always have a path. Like, for instance, like I had brought up earlier in the meeting today, DCBS has a complaint process, but it's designed for consumers. It's not designed for providers. And we're really wanting to figure out how to be proactive rather than reactive, because the reactive approach really hasn't worked. We've seen that in the federal report at the federal level, that it really hasn't worked. And we just want to make sure that we're not reacting to non-compliant review practices after they're already out there and being done, because that's how we've been doing it in the past. And it's something that we're going to continue thinking about. And we're going to be looking at how these rules are written and seeing if we can make some suggestions. But definitely concerned about the other criteria being released without somebody looking and seeing whether it's compliant beforehand.
Yeah, and Melissa, my concern is, with the health plans, we are transparent to the regulator. It's getting into whether or not what our medical and professional people think is valid treatment plans versus what the regulator, and then go into an IRO. So I agree with you. We want to get ahead of it too and be proactive, but in doing so, are we putting up barriers and limits that are unintended? So thank you. That is it.
Great, we'll move on to Bennett.
Just a quick question, and maybe I'm the only one who doesn't really understand it. How much transparency is required? I mean, one of the things in the past has been that particularly some of these commercial products have been proprietary and there's been no transparency. So I think, to me, if you're going to do something that's not vetted by a professional organization, that it's important that all the criteria be completely transparent and the justification for those criteria be transparent as well.
Yeah, I believe it's in the Consumers' Rights Notice in the 740 or 743B somewhere, that they can request copies of, I believe, of our I think it's internal policies and some of the criteria we use. I know at Pacific Source we do put some of that out on the website. So there is areas out there that can be used, and when a member appeals, I believe they can look at that information too. And Tasha or Cassie, you may know more, but I believe consumers do have access in that area.
Well, I would just advocate proactively that providers have that information in advance so they know the rules that they're working under, rather than having to go find it in some obscure place.
Well, yeah, I mean, there's pros and cons there.
I do want to just add, again, if we kind of follow Dan's suggestion of using exact statutory language, it does say in 5A C at the end, such other criteria and guidelines must be made publicly available and made available to insurers upon request to the extent, permitted by copyright law. So, I mean, it is in the bill, and, I mean, where it is located, I can't help you there, but I mean, everybody does it differently, but it is required.
Melissa, and then I think we're gonna have to wrap up our time because it's almost 11 o'clock. Go for it, Melissa.
Yeah, just, just because I know we all have a lot to read, and I don't know, I don't read every single thing. I just want to, again, draw your attention to our submission for today and the fact that we included as attachments a couple of letters that have been sent to providers from a third-party company, Change Healthcare. And we just really think that the letters speak for themselves and that they are clearly, intimidation and using tactics to intimidate providers into changing the way that they provide treatment. They don't have anything in the letters that they're based on generally accepted standards of care or medical necessity, and we just feel like reading those letters speaks for itself.
And Bennett, I see that your hand is up. Is that leftover from? Okay, great. Just want to make sure. One question that I will throw out to the group, not to respond to today since we are getting close on time, but for kind of when you're taking the rule back to your teams to look at this, one of the questions that has come up around kind of specificity for the DSM, but also there's sort of a question that was raised by Pacific Source around specificity of the standards, so the criteria, and I think getting some information from you all on how best we can describe this in rule or how we construct it would be super helpful, since there are a number of criteria that are out there, and I know that we've been talking about some of it, but kind of if you have information on how to help kind of with that specificity, that would be helpful. All right. Moving on, we will open up the public comment portion of the meeting. And if you are a member of the public and would like to provide public comment, feel free to raise your hand, or if you are on the phone, I think it's *6 to unmute. I'll pause here and see if we have any public comments. Rick.
Hey everyone, I'm Rick Blackwell from Pacific Source, member of the public. So I just want to echo what Dan had said about incorporating provisions of the Act into the rules. I understand for convenience, it would, you would want to put those in the rule, but if they're not done exact, we'll have problems with interpretation. And the point of rulemaking is really to clarify the bill, not necessarily to rewrite portions of the rules. Like for instance, the discussion we just had on section 9 of what is this, Rule 1405, regarding what the generally accepted standards of care and recent version of professional or placement criteria. I don't know that the bill actually supports that interpretation of having and. It looks like there's placement of care criteria as a subcategory, and that's where the professional associations come into play. So I think we just need to be really careful about incorporating the Act. I think maybe, Cassie, if it's helpful, we should use the email that I sent to Brooke on Friday as a public comment so people can understand where we're coming from with respect to how agencies incorporate standards into law, and the case laws that goes into how the Oregon Supreme Court has interpreted that time and again. And I was going to talk about the essential health benefits, but I don't think I need to do that. I don't know if the division has had any conversations with the Oregon Health Authority regarding whether any of the what we're discussing here in rule will affect how the individual market plans work, and whether has to be a mandate defrayal analysis that goes along with that. So those would be my comments. Really appreciate the time, and I hope we got a few more minutes in case anyone else needs to speak.
Thanks, Rick. Anyone else want to provide public comment? All right, I am not seeing any other hands or hearing anyone unmuted. Just as a reminder to RAC members and also members of the public, you can comment written comments to us that we will send out to the RAC and also consider. In terms of next steps, the next RAC meeting is scheduled for Thursday, May 19th from 9:30 to 11. If you do have any comments, please provide them to the DFR staff. So Brooke, Lisa, Karen, and myself by May 1st. You can send it to any of us and we will get it to the rest of the crew. Appreciate the time today and the I think there's several things that we'll be looking into and hope that you and your teams take a look as well and can provide some information back to us. With that, I will wrap up unless there are any other questions or comments from RAC members. All right. I hope that you all have a lovely Tuesday and we will talk to you all soon.
Thank you.
Thank you.
Thank you.
Thank you.